Hello everyone, how are you all? So thank you so much for joining our today's session. As you know that today's session is based on our three classes that we have taken so far on cardiology. So we'll be doing the questions related to cardiology. Now obviously there are lots of questions that can come from cardiology. We will just try to do some of those questions which is important for your exam and which is a little hard. If you know how to solve these questions, then you will be able to solve many other questions as well. All right, so we are waiting for 2 more minutes to start the session. But before we do that, do you guys have any questions on any of the previous sessions that we have taken? Feel free to ask it now. I will be able to answer any of your queries. All right, so let's start then. So this is our first question. We have got a patient who is 17-year-old. It's a male who was running a race and suddenly collapses on the floor. Luckily, someone was there and performed CPR as patient did not have a palpable pulse and resuscitated him. Upon arrival to the ED, it is revealed that his father died at the age of 28. He is now alert, asymptomatic, ECG was non-eventful, and he is anxious to go home. What do you do next? Now, looking at the questions, always remember in a questions, there will be some of the clues which will help you to diagnose the question or diagnose the case, or there will be something which will make you more confused. So you have to understand that which one is the clue and which one is the trap for you. So these trap and tricks are important to find out the exact questions and exact answer of that particular question in the exam. So it's very important to understand a question rather than just reading. When you read a question, always don't bother with the whole scenario. See that when I was reading, I marked these things because these are the important things. It's a age is important, was it's a male or female is important. Then what exactly he was doing? He was running a race, and what happened during running a race? He suddenly collapsed. Collapse means syncope. And also you see that he has a history that his father died early age. So early cardiac death in the family is one of the very important clue for mainly two conditions. One, it could be HOCM, right? Or sometimes it can happen in the prolonged QT syndrome, which is congenital QT syndrome. These two are the mainly important for sudden cardiac death history in the family. Okay, now what do you want to do in this patient? You want to send him home and arrange an outpatient consultation with a cardiologist. See that there is a clue here that he is anxious to go home. Anyone who is anxious like this, don't just send them home. That's not appropriate. So, and the B option is sending him to home. No, obviously. Admit and refer for cardiologist team consultation, outpatient echocardiogram, stress echocardiogram. Now, all these three options are okay. Like we will obviously do an echocardiogram, but remember a stress echocardiogram is not our first option to do. We will do a stress echocardiogram only if you do a echocardiogram, like just a normal echocardiogram. If that comes negative and still you are suspicious of HOCM, then you only do a stress echo. A stress echo is not the initial thing to do. So it's not a good option at this time. Obviously, later on we can think about it. After that, we have C and D. So do you want to order an outpatient echo, or you want to admit the patient and refer for cardiologist team consultation? Now, between these two, I would not choose outpatient echocardiogram because this patient just just like couple of minutes ago, this patient needed a CPR because he was totally collapsed and he did not have any pulse. So this patient is not a good candidate to send him home at this time. On the top of that, he has a history of sudden cardiac death in the family. What if you send this patient home and then the patient died? It can happen. This sort of patient, that's why they need all the imaging, all the investigations, everything is needed before you send this patient to the home. So better in here you admit this patient and you can refer to the cardiologist team for consultation. Now the cardiologist will come and they will do the appropriate investigation and everything for this patient, because this patient will need referral to a cardiologist. If you refer in a outpatient cardiologist, it will take months and months to get a specialist referral in Australia, which this patient doesn't have. So it's a better idea to send to the hospital or admit to the hospital and then involve the cardiologist in the hospital. Clear? So a better option in here is to choose the C. Cool. Any question from this case? So always when you choose any option in the exam, it's very important to think and use your logic that what you want to do. In this case or in these options, if there was only one option, like in the D option, it was not an outpatient, just echocardiogram, then we would choose that one, because if this patient will need a echocardiogram, so if echo was the only option rather than a stress echo at this time, then we would choose that. Okay, the next one. A young athlete presents with history of sudden syncope and dyspnea. ECG shows left ventricular hypertrophy. Patient's father had sudden death at very young age. What is your initial treatment for this patient? So what do you think would be the initial treatment in this patient? Now, remember this patient had syncope and a sudden cardiac death in the family. So most likely this is a case of HOCM again. Now in HOCM, what sort of heart failure occurs? Remember in HOCM what happens is that this is the heart, the intraventricular septum gets hypertrophied, right? And due to that, heart doesn't get enough space to fill in, so it cannot relax properly, so it occurs as a diastolic heart failure. For diastolic heart failure, what sort of medication we usually give? We give rate limiting drugs. We have calcium channel blocker, we have beta blockers. In here, I can see there is only verapamil. Verapamil is your rate limiting calcium channel blocker. So this will be our initial treatment for this patient. We discussed this case. If you remember, just previous class, we discussed about this HOCM. So in HOCM, the main treatment is beta blocker or calcium channel blocker, diltiazem or verapamil. Okay. Initially, you don't need to give implantable defibrillator or surgery. These are not initial management. These will be for more severe or frequent syncopal patient. We can give implantable defibrillator, but not initially. We'll first try the medication. All right. And the other option, if you go through the other option always. Septal myomectomy is a surgery which we don't do initially. Again, defibrillator not initially. Low molecular weight heparin is not indicated in HOCM. Again, adenosine is not indicated in HOCM. Adenosine is only indicated in supraventricular tachycardia. Clear? Now the next question, again, this is a case of HOCM. I'm showing you how many questions can appear just from a one topic. A young girl, 15-year-old, collapsed at exercise. Her father had HOCM. After ECG and echo, you found no abnormality. What is your next step to do? Now in here, you understand what you will do now. So you have already done a ECG and a echocardiogram. You did not find any abnormality. What should be your next thing to do? Halter, stress echo, repeat echo, or repeat echo after 3 years. So you already did echocardiogram. Now you want to do a stress echocardiogram. Clear? So see that this is how the question can come. Next question. A 9-year-old male was running, playing football, and suddenly collapses on the floor. Upon arrival to the ED, it revealed that his father died at the age of 28. He is now alert, asymptomatic. What would you do next? Halter, stress echo, repeat echo after 3 years, ECG, echocardiogram. Now you tell me what you want to do in this patient, because right now you haven't done anything. So what should be your first thing to do? They're asking the next. Next means the initial one you want to do. For I said in our previous class that every patient who is coming to you with chest related causes, that means CVS related causes, you should always order a ECG first. ECG, guys, why echocardiogram? They are asking for next. Even you can see in this question after ECG and echo. So they have done a ECG, they have done a echo, then the stress echo. Remember, any patient coming to you with heart-related problem, always you do a ECG first. Even though in here ECG might not give you any finding, but sometimes it can show left ventricular hypertrophy in the ECG. But we always do ECG in these patients. So next we'll be doing a ECG first. If they ask what would you do for diagnosis? For diagnosis, obviously, we had to do a echocardiogram. Or if they would ask you what would lead you to the diagnosis, or which investigation would lead you to the diagnosis, that's echo. Or if they would ask what is the most appropriate investigation to do, echocardiogram. If they would ask you what is the next most appropriate investigation, whenever there is next, it means the initial investigation they are asking. Initial, we always do ECG. Here, guys, don't get confused with these main things. If you don't understand what they mean by next, best, appropriate, then you will not go forward. You will know the answer, but it's still just because of this question pattern, you may miss very, very important questions. Clear, guys? So this will be our ECG. Now move on to the next question. A 16-year-old male who presents with ejection murmur in second left intercostal space, which of the following is likely to be the diagnosis? So you have got a 16-year-old male. First of all, it's the male and age is 16 years. And having a ejection murmur in the second left intercostal space. So if you see this, let's assume this is the second intercostal space and this is the second left intercostal space. If it is second left intercostal space, then what would be your most likely diagnosis? First of all, remember, well, aortic stenosis gives you ejection systolic murmur, but where you will get the murmur of aortic stenosis? Is it in the left side or right side? Remember, I said something about the aortic and pulmonary? Yes. So aortic stenosis murmur should be in the right because your aorta comes like this. So the stenosis murmur always happens in the right side. So if it is a second left intercostal space, it's not aortic stenosis. So this patient has ASD. By the look of the option, you know that this patient obviously has atrial septal defect. With ASD, something else also happened, also is there. We need to find this out. So now let's see mitral stenosis. Where you get mitral stenosis murmur? You get mitral stenosis or any mitral valve murmur in the apex, which is your left fifth intercostal space. So this one is also out. Aortic regurgitation. Where you get aortic regurgitation murmur? You get aortic regurgitation murmur in the left fourth intercostal space. Remember, left fourth intercostal space along the sternal border. Okay, so this aortic regurgitation murmur also out because this patient having second left intercostal space. Now, second left, you can get a pulmonary hypertension. Even pulmonary hypertension may not cause murmur, but if you have pulmonary hypertension, you will get palpable P2 in the second left intercostal space. And if you have pulmonary stenosis or even due to pulmonary stenosis, you develop pulmonary hypertension, sometimes you can get murmur in the second left intercostal space. The main thing from here is that any pulmonary problem, even is pulmonary stenosis, pulmonary hypertension, whatever it is, pulmonary problem, you will get murmur in the second left intercostal space. No aortic or mitral valve problem will give you murmur in the second left. Clear? Now, if we go into this thing, this is a little bit of confusing because pulmonary hypertension itself doesn't cause any murmur. Maybe there is some underlying pulmonary stenosis, something like that, that's causing this murmur. Okay, so it just to make you confused, but you need to understand how to rule the options. So if you rule out the other options, then only thing remains is the pulmonary hypertension. Now, if you look at the atrial septal defect, it's mainly present in the children, can be there in older children also. Patient usually have a murmur, which is systolic ejection murmur along the left upper sternal border from increased pulmonary flow. That's so you understand what's happening here in aortic, in atrial septal defect. Let's see this one. So this is your atrial septal defect. This is the atrial septum. If there is any defect in this septum, then what will happen? Blood will go from the left atrium to the right atrium, right? And as blood is coming from the left to the right atrium, then there is increased blood flow in the right atrium. So more blood will go to the right ventricle and more blood will go from the pulmonary valve and pulmonary artery. That will lead to pulmonary hypertension. So eventually ASD is causing pulmonary hypertension. And when there is increased flow from the pulmonary artery, you can get a flow murmur, which is your, which can be even this ejection systolic murmur you can hear in these pulmonary areas. Clear? So in physical examination of ASD, you will get ejection systolic murmur in the left mid to upper sternal border. So we have got our answer left, also upper sternal border, which could be usually upper sternal border means second or third intercostal space. Okay. And also remember your VSD, which is the most common congenital heart lesion, it gives you pansystolic murmur at the left lower sternal border. Okay, just remember these two murmur because we haven't discussed these two murmur in our theory session. It's usually we discussed in the pediatric cardiology. But just remember these two. In VSD, you get a pansystolic murmur at the left lower sternal border, whereas in ASD, you get ejection systolic murmur in the upper left sternal border. So our answer will be ASD with pulmonary hypertension. So if you don't have a good idea on this murmur, it's very, very hard to rule this out. That's why you need to use my theory. Remember how I shown you how to find out the murmur? Use that and it will be really easy. So clear guys, any confusion with this question? Good. And also you can go through the med bullets to find out more about the murmur. Next question. A young guy while playing cricket suddenly had a syncopal attack without any convulsive features. Soon he spontaneously recovered and started fielding and continued playing the rest of the game. What was the cause? Now, syncope means loss of consciousness. There are lots of syncopal attack. We haven't discussed the syncope, that's why I kept it for today's session so that we can discuss it. In syncope, there are lots of syncopal attack that can happen. One is your cardiogenic syncope, another is vasovagal syncope. Sometimes people with epilepsy can have a syncopal attack. Patient with neurological issues can have neurogenic syncope, or even sometimes just with changing the position from like sitting to standing position, with just changing the position, patient can have a syncope, which we call postural hypotension. In such case, what we need to find out that if this patient had any prodromal symptoms or not. Depending on that, we can find out what type of syncopal attack it was. Let me show you a very good link for syncope. Look at this picture. So loss of consciousness means syncopal attack. Syncope can happen very suddenly. Syncope can happen gradually. If you have a gradual loss of consciousness, which means that you had a prodromal symptoms, like what happened before you lost consciousness, you felt funny or you felt blurry vision, you became sweaty, pale, and you knew that you are going to fall. So if you had this sort of prodromal symptoms and later on you fall and then you gradually regain consciousness again, that's mainly vasovagal syncope. So in vasovagal syncope, you usually get these prodromal symptoms. Mainly prodromal symptoms are you will feel blurry vision, sweaty, pale, hot, okay, and sometimes you can even get headache, and then you will gradually get those prodromal symptoms and fall and lose consciousness, and then you gradually regain your consciousness. So that's your vasovagal syncope. The other syncope, which happens suddenly, that you will not feel any prodromal symptoms, there are two main causes. One is cardiogenic, another is neurogenic. Now, in cardiogenic syncope, you will regain consciousness also suddenly without any confusion afterwards. So you lose consciousness suddenly, you regain consciousness suddenly without any confusion. That's your cardiogenic syncope. Now you lose consciousness suddenly, but you regain consciousness gradually. That's probably neurogenic. Now neurologic or neurogenic syncope, most of the time it could be seizure, which is your epilepsy, or sometimes brain tumor, head injury, anything can cause this sort of problem. All right. At that time, we need to order a EEG and a head CT scan to rule out stroke, to rule out epilepsy. Now, if it is a cardiogenic syncope, then you need to do a cardio examination. So it could be myocardial infarction, it could be valvular disorder, it could be HOCM. So depending on that, we will order more sophisticated investigation for heart. Clear, guys? So the main thing is to understand how these most three important causes of syncope presents to you. If it is a sudden onset of loss of consciousness with sudden regain consciousness, that's cardiogenic. Sudden loss of consciousness but gradual regain consciousness, that's neurologic. Gradually loss of consciousness and gradually regain consciousness, that's mainly vasovagal. Now, if we come to the question again, what do you think this guy had? Young guy, while playing cricket, suddenly had a syncopal attack without any convulsive features. Without any convulsive features means that this is not a epilepsy. So you can rule out epilepsy in one go. Soon he spontaneously recovered and started fielding, continue playing the rest of the game. That means sudden onset of loss of consciousness and suddenly he also regained consciousness without any other confusion. So what was the cause? Cardiac syncope, right? Good. So most likely we would go for like either most likely it's a HOCM case. HOCM usually comes with this young patient. Okay. Vasovagal syncope, if it was a vasovagal, usually they would have some prodromal symptoms, which was not here. So it's unlikely to be a vasovagal. So what's our answer? Cardiac syncope. All right. So see that if there is post-ictal state means if there is after regaining the consciousness, if a patient has confusion, that's mainly post-ictal stage. Post-ictal stage is mainly for seizure or epilepsy. That means they usually will bite their tongue, lose urine, or wet their pants, and then they will have confusion for more than 30 minutes. That's called post-ictal state. That's mainly for seizure. If there is prodromal signs, then more with vasovagal. If there is no prodromal sign and recover immediately, more with cardiogenic. Okay. In neurogenic, goes suddenly, comes back in minutes. That means it takes some time to regain consciousness. Now, what about postural hypotension? Postural hypotension is mainly common for elderly patient who is on a lot of medications. Usually what happens, the question will give you that whenever patient had some syncopal attack at the home, but normally patient gets dizzy or patient fall or patient lose consciousness when wake up from the bed at the morning. So when they wake up from the bed at the morning, what they do, they change their position from sitting to the standing position. So whenever they change their position, they feel or they have the sort of syncopal attack. That's for postural hypotension. Clear? Next question. Any question? Those who are in the Facebook? Good. Let's move on. If sound is not loud enough, you should use the headphone. Okay. Try to use the headphone. It should be fine. I'm actually using the headphone and I can see my sound bar is moving like up to the highest limit. So in from my part, it should not have any problem. So most likely it's a good idea to use the headphone if you are having any trouble with the sound. Okay, Dr. Shirin. The next one, a 45-year-old male presented to the emergency department with the left-sided chest pain radiating to the left arm and jaw. So 45-year-old man presented to the emergency department with left-sided chest pain radiating to the left arm and jaw. That's pretty much the feature of myocardial infarction or angina. There is no ECG changes and troponin is negative 4 hours since the onset of chest pain. Their patient has been on sildenafil for erectile dysfunction, metformin for type 2 diabetes, ramipril for hypertension. What would be the most appropriate next treatment? Now look at this question. What do you think? First of all, this patient presented to you within 4 hours of onset of chest pain. Now, within the 4 hours, there is no ECG change, troponin negative. Now, you cannot say that this patient doesn't have my MI. Maybe troponin negative, it will get elevated after 4 hours. So, if there was an option to repeat ECG or repeat troponin, that would be the best option of treatment. That option is not here. In here, all the medication are the options. So, what you want to do in here? Obviously, heparin is not needed at this point unless troponin is elevated. If troponin is elevated, then only you give heparin. Otherwise, no indication of giving a heparin to this patient. Okay. If there is ST elevation, then you send this patient to the catheter lab. If there is no ST elevation, but troponin increased, which means non-ST elevated MI, at that time you give heparin. If ECG negative, troponin negative, that means it's an unstable angina. For unstable angina, we don't need to give heparin. All right. So what you can give to this patient? Well, you could give nitrate to this patient because it's a GTN, but why you cannot give GTN to this particular patient? Was there any reason for that? Yes, patient is on sildenafil, so it's contraindicated to give GTN to a patient who is taking sildenafil. At least 24 hours or 48 hours should be delayed. So nitrate is out. And if patient was not on sildenafil, nitrate would be a good option to choose. Then what else? Heparin, still now we cannot give it. Beta blocker, we can give it to every unstable angina patient or angina patient. That's a good choice of treatment. And paracetamol, at this point, no need. Now, as this patient is having chest pain and chest pains are really severe, for chest pain, you can give morphine in this patient. For this particular question, we don't have any other choice. So we have morphine from the monotherapy. So MONA. In this patient, if aspirin is an option, that would be the best option to start with. That's not in here. Again, nitrate is here, but we cannot give it. Oxygen not needed because this patient, I can't see anywhere they have written saturation is low. Only thing that we can give for the chest pain is the morphine. Okay, so morphine would be a good option to choose. Good, Dr. Sonia. Yes, both are vasodilators. So nitrate, sildenafil, both of them can cause like profound hypotension. So that's why we don't give it. Good. All right then. The next option. You have got a 72-year-old male who presented with severe chest pain radiating to his back. On cardiac examination, you notice diastolic murmur. Chest X-ray shows widening of the mediastinum. ECG given. What is the most appropriate management? Now, look at the question. 72-year-old male comes to you with severe chest pain radiating to the back. Chest pain radiating to the back in elderly, you should always think about aortic dissection. On the top of that, you have got diastolic murmur. Sometimes diastolic murmur can happen in dissection if they develop aortic regurgitation. And chest X-ray shows widening of the mediastinum. ECG is given. If you look at the ECG, you will find out very good ECG in here. Look at the lead 1. Lead 1 doesn't have any ST elevation. Now lead 2, this is the baseline. This patient having ST elevation in lead 2, lead 3, lead AVF. Now lead 2, 3 AVF is your inferior lead, which means inferior MI. If you look at the V1, this is the baseline and there is ST depression. V2 having ST depression. V3 having ST depression. But V4, V5, V6 having ST elevation. Now I understand that we haven't done the ECG and it might be quite difficult for you to get these sort of things. But don't worry, I'm just letting you accustom to this ECG so that when we take the ECG class, you get this more better way. All right. So we have got a patient with ST elevation in the lead 2, 3 AVF, ST depression in V1, V2, V3, and some ST elevation in V4, V5, V6. Obviously, this patient having inferior MI. If it's an inferior MI, can it happen in aortic dissection? Yes. How? If the dissection occurs in the proximal part of the aortic root, from the aortic root, the coronary arteries also arise. So if the dissection involves the coronary arteries, then you can develop MI on the top of aortic dissection. Clear? So this patient having both, which is very, very severe. Now, what will be the management for this patient? Do you want to give a thrombolytics to this patient because of ST elevation? No, because if you give thrombolytics in a patient who is having dissection, you're going to kill that patient. So, no. Give aspirin and intravenous morphine. Well, they are asking for the most appropriate. We will, this one, okay, but we will look for some other. Give morphine, give morphine, beta blocker, arrange for transesophageal echocardiogram, refer the patient to the cardiology clinic. Obviously, we will refer to the cardiology clinic, but before that, we have something to do. Consider urgent MRI. Urgent MRI is not needed. Referral at this point, not needed. Now, between B and C, what gives you the best way of managing this patient? Obviously, for your aortic dissection, better to start the patient with beta blocker, right? And also arrange an urgent echocardiogram that will help you to diagnose aortic dissection. And for the pain, you can give morphine. The main problem in here is the dissection, which causing the MI. So you have to treat the dissection to treat the MI. If there is continuous dissection, even if you treat MI, there will be nothing. So you have to treat the dissection because dissection is more life-threatening. Okay. Now for that, you have to give morphine because patient having severe chest pain. Give beta blocker, although it might not be very much effective for this sort of dissection, but it's a good idea to start with. And then obviously we need to confirm the diagnosis by doing the urgent echocardiogram. Giving aspirin and morphine doesn't seem to be the most appropriate management. We can, as a next management, yes, aspirin, morphine is a good idea, but for the most appropriate or best thing, better option to choose is the C. Okay. Always, Dr. Francis, so always think in a broad way, which is the best for this patient. You cannot, if you choose B, you are not thinking about aortic dissection. Okay, they're asking to you most appropriate. So obviously in this case, they have given you all the feature of aortic dissection. If you just choose B, that means you are not thinking about aortic dissection, you are just trying to treat the MI. Okay, so obviously the best option in here will be a C, which will give us the both things together. Good. Clear, guys? So this is very important for your exam, these sort of things. You have to be very careful when you choose options. So this is the widening of the mediastinum. You can see how much widen, and you can see the prominent aortic knuckle. All right. So, Dr. Ridhima, for aortic dissection, what is the initial investigation? Chest X-ray or transesophageal echo? Now, it depends on how the question comes to you. If it's really severe and it's very much diagnostic that it's aortic dissection, we don't even need to do chest X-ray. So it depends. Like patient will present to you with chest pain, right? Even before X-ray, you need to do a ECG. So I don't think X-ray will be an option. X-ray will be option, but not the correct option in any time. So initially, we would do ECG. If the patient is not hypotensive or unstable, We can start with the X-ray and do the transesophageal echocardiogram later on. But if patient unstable, we don't have the time to do a X-ray chest. We will go for echocardiogram immediately. Yeah. So it's better to like, I think it will be better thing whenever patient presents to you chest pain, try to rule out MI first. So ECG should be the first option to choose as the initial. Next question. Elderly man with multiple falls during the day, especially in the morning after waking up. So you have got an elderly man having multiple fall and especially after waking up. What's your diagnosis? Just by the first line, I understand it should be a case of postural hypotension. Because postural hypotension usually comes to you with frequent falls, especially when they wake up in the morning from the bed. ECG found LVH, that means left ventricular hypertrophy, multiple ventricular ectopics. Orthostatic hypotension was also noted. How will you investigate further? Now, you already find out orthostatic hypotension. Now, further, you have to find out the question pattern. They are asking how will you investigate further. If they would ask you, what will you do next? Next, I would do A, because I want to confirm my diagnosis of postural hypertension. I would do repetitive measure of blood pressure in supine and prone position, which is the next thing to do. But they are asking, you already found out postural hypotension or orthostatic hypotension, how you are going to investigate further that why this patient having fall. Is there any other reason to? So how you can find it out? By doing a 24-hour Holter monitoring. If you do the Holter, then you will be able to find out if there is any underlying cardiac syncopal causes. Like patient having multiple ectopics, maybe there can be something more than that. If you do a 24-hour Holter monitoring, then it will record everything. Okay, because you already find out that ECG showing something, so it's better to find out if there is anything else. First, Dr. Asha, we will go for transesophageal echocardiogram in case of aortic dissection because it's given in your JM. Yeah, normally we do supine and standing position for orthostatic hypotension. And also, yeah, that's also a good thing you say, Dr. Asha. So I was going to say this one. So even in here, we would not choose this option because they say that you will do it in supine and prone position. We don't do it supine and prone position to find out orthostatic hypotension. We check it in a standing and lying position or standing and sitting position. So even though if they would ask it as a next, in this case, we would not choose A because they're saying they would do it in supine and prone position, which we don't do. For orthostatic hypotension, we check it in the sitting or lying position and standing position. Clear? So if you find out a patient who is having postural hypotension, the next thing to do is to repeat it multiple times throughout the day in both positions to confirm the diagnosis. And after that, sometimes patient can have some underlying cardiac causes which is causing this fall. And you already find out in the ECG there is left ventricular hypertrophy, there is ventricular ectopics. So sometimes there can be more. So all these elderly patients, usually when they are in the hospital, they usually put this patient under the 24-hour telemetry or ECG Holter monitoring. This is the same thing. If in the option they write telemetry, always think that it's the more or less Same like Holter monitoring. Clear? So whatever is in the option, we will choose that. Next, a young patient has been getting multiple lightheadedness and dizziness. His clinical features are normal, chest X-ray ECG normal, Holter monitor reveals ventricular ectopics. What will you do next? So young patient coming to you with multiple episode of lightheadedness and dizziness, no clinical features, ECG normal, X-ray normal, Holter monitor showing just some ventricular ectopics. Do you want to reassure? You want to do exercise tolerance test, dobutamine echo, plain echo. Now look at the ventricular ectopics from your JM. The ventricular ectopics are usually asymptomatic in 90% cases, and it can happen 20% with just a normal heart. More common when the patient takes rest at bed in night. Usually, if it's the elderly patient, we try to find out any evidence of underlying ischemic heart disease, mitral valve prolapse, thyrotoxicosis, or left ventricular failure. If symptomatic but otherwise well, with a normal chest X-ray and ECG, reassure the patient. So our patient is symptomatic because lightheadedness and dizziness are there, but normal chest X-ray, normal ECG, even normal, if and only when you did the Holter, you find out the ectopic. So in this case, what you can do, you can reassure the patient. Okay. But in this case, like if this case was not a young patient, but it was an elderly patient who is having multiple fall and multiple syncopal attack or lightheadedness dizziness, what you would do, you should do a echocardiogram, because that patient, elderly patient, if they fall, they has more chances of getting head injury, trauma later on, brain hemorrhage. So in those patient, in elderly patient, ventricular ectopics or anything which causing fall or syncope, we would go for the echocardiogram. Let me explain echocardiogram. But in this patient is a young patient, all right, and others are all normal. ECG, X-ray, clinical features, everything normal. We can just reassure them. But same patient, if it was elderly or middle aged, we would do a plain echo. Clear? And sometimes for ventricular ectopics, if the patient having troublesome symptoms, you can prescribe beta blocker to them. But when you want to give this patient a specific treatment, like antiarrhythmic treatment, then you should always do a echocardiogram first. So never commence drug treatment without performing an echo, because class 1 antiarrhythmics can make this arrhythmia life-threatening. And in that case, you need to refer this patient to a cardiologist. But most of the patient with ventricular ectopics doesn't need any specific treatment. It's very common unless it's an elderly patient and very much symptomatic. Okay, always, usually, like if you look at the Holter monitoring of a elderly patient, you will find out some PVC in every patient. Unless they are very symptomatic, we don't need to give any medications to them. But obviously, if it's a young adult patient, we don't need to do anything. We will just monitor the patient. So you can reassure them if X-ray and ECG are normal. Any questions so far, guys? All right, we'll take a 10-minute break now and then we'll start again. Thank you all. So 10-minute break. All right, guys, so let's start again. So this is our next question. So you have got a patient who is on amlodipine, amiodarone, furosemide aspirin, and has been having intermittent falls. And they're asking you the most likely reason for that. And this is the kind of drug interaction kind of questions, which is very commonly asked in the exam. So you have to have some good idea on the drug most important side effects. And it's very common to ask about the hyperkalemia, then prolonged QT syndrome, those sort of things comes in the exam. So ECG was given, which looked like hyperkalemia. In hyperkalemia, the ECG will show tall peaked T wave mainly. You can have broad QRS complex. These are more common. Now, which one out of these four options can cause hyperkalemia? This question was like a little bit of confusing because none of these options seems to be really correct to me, or like this is like a very confusing scenario for your exam. Now have a look at this, that aspirin and furosemide causes mainly hypokalemia. Even if normally NSAID can cause hyperkalemia, aspirin doesn't have severe effects of causing hyperkalemia. But even though if it was causing hyperkalemia, furosemide causes low potassium. It should counteract with the increased potassium caused by the aspirin. Okay, same in this case. Normally aspirin doesn't cause hyperkalemia, so even that we don't actually think about hyperkalemia in this option. Same like amlodipine furosemide will cause hypokalemia, so it's unlikely to be the answer. Now between this B and C, there is a very slight chance that amiodarone can cause hyperkalemia. Okay, just because of amiodarone, this is a good option to choose, but it's not like significantly there any of these options, not never ever I have heard that these things cause a significant hyperkalemia, and I haven't found any good link to show it to you. But out of these four options, only I know that amiodarone causes a little bit of hyperkalemia, so it's a better idea to choose this option rather than other option, but it's a kind of vague. Okay, but sometimes these sort of things can come in your exam. It's a good idea to know about this. All right, then you have got another drug interaction scenario about multiple drug including ramipril, amlodipine, hydrochlorothiazide, celecoxib, asking about which combination can cause muscle weakness without muscle tenderness. Now, obviously, it's important to understand many of these drug has some effect on potassium, and even hypokalemia can cause muscle weakness. Hyperkalemia can cause muscle weakness. You need to have a look that if there is any chance that any of these drug interaction causing hypo or hyperkalemia. So look at this option. Celecoxib is your NSAID. It can cause hyperkalemia. But thiazides causes hypokalemia. So both of them will counteract each other. So there will be no increased potassium or decreased potassium. This option is out. You have got ramipril, which will increase potassium because it's a ACE inhibitor. Hydrochlorothiazide will decrease potassium. So again, it will counteract. Now, amiloride is a potassium sparing diuretics, and ramipril also increase potassium. Now both of them will increase potassium, so that will cause hyperkalemia, And again, hyperkalemia itself can cause muscle weakness. So that's your most likely option. So this is how in the exam you can get multiple drug interactions and you need to find out which drug interaction is the most appropriate. Clear, guys? Any question from this? Next, ECG of an adult presented with chest pain, cardiac enzyme and first ECG normal, blood pressure okay. After 8 hours of observation, his BP goes down to 89 by 50. ECG showing SVT with heart rate 150. What would you do? Now, obviously, I remember that we haven't discussed supraventricular tachycardia in our theory class, but we will discuss that very soon in our next session, which we will start after this 2 weeks free session. We'll do the ECG in which we will finish our palpitations. Now, just to give you some heads up about these palpitations and to do some questions related to that, remember any patient having supraventricular tachycardia, there are mainly two options we can think about. One option is if the patient is vitally stable, like blood pressure is normal, mentally normal, that means there is no altered mental status, there is no chest pain, there is no shortness of breath. Okay, so four things actually says that these patients are stable: no shortness of breath, no chest pain, blood pressure normal, and mental status is also normal. Now, vitally stable patient with SVT, the initial treatment will be starting with the vagal maneuver. Like you can try carotid massage, you can try immersion of the face in cold water, you can try any vasovagal stimulation or vagal maneuver. So whatever it is, you can do that. If that doesn't help, then we go for pharmacological treatment with adenosine, or sometimes even you can try calcium channel blocker like verapamil. So mainly adenosine is given in a stable patient. Now in this patient, is it stable or unstable? You see the blood pressure is 89 by 50, which means that this patient is not stable. For any unstable patient, we need to go for DC cardioversion. The DC cardioversion, the another name is synchronized cardioversion. So this will be your option to choose in here. Any supraventricular tachycardia, if it is an unstable patient, the term we use is the DC cardioversion. If it's a ventricular tachycardia having no pulse, if it is a ventricular fibrillation, then what we give with the unstable patient? Defibrillation, which is unsynchronized cardioversion. We will discuss about those synchronizing and unsynchronizing in our palpitations class. But just to let you know, other option like atropine is given in bradycardia symptomatic patient. Flecainide is a rhythm controlling drug, mainly we use in atrial fibrillation. Again, adenosine we use in SVT, which patients are stable and did not respond to the vagal maneuver. Then we try adenosine. Cool. So this is your answer in this case. Next question. Patient is on digoxin, bisoprolol, thiazides, long-term history of hypertension and congestive heart failure, also atrial fibrillation. He stopped taking medication for 3 weeks while on vacations. Now presents with edema up to his knees, raised JVP of 4 centimeter, but with clear chest sound. Remember, I said it in the theory class, the same question. BP 145 by 90, pulse irregular because of AF. What would you do as an initial management of this patient? So now tell me, is this a decompensated heart failure with a pulmonary edema, or it's just heart failure but no pulmonary edema? Does this patient have pulmonary edema? What do you think? No, this patient doesn't have pulmonary edema because you see that it's clear chest sound, which means there is no bibasal creps, which means it's not pulmonary edema. If it is not a pulmonary edema, you don't need to start the patient with furosemide at this time. So what the patient can take, patient can recommence all her medication at this time. So recommence all the medication for this patient. We don't need to start with the furosemide for this patient. What if this patient had bibasal creps? If it was bibasal creps, then you would start the patient with furosemide. Okay. And don't think that this patient will need at this time patient already on bisoprolol. What is bisoprolol? It's a beta blocker, right? So you don't need to give metoprolol on the top of bisoprolol. It will be like two beta blocker at the same time. So patient already having every medication she needs for her heart failure. So she is on digoxin, she is on bisoprolol. In this question also patient was on ramipril as per I remember. So everything was there. So you don't need to give anything to this patient. But if this patient was not on thiazide diuretics and patient had pulmonary edema, then you need to start with some diuretics. Especially we would start with the furosemide, spironolactone at that time. But this patient already having everything previously. So you can just recommence all those medication. Clear? Just the point of this question is that if patient is not having pulmonary edema, shortness of breath, then you don't need to just start with diuretics. You can recommence all the medication. If pulmonary edema is there and patient is not on any diuretics, you need to start the patient with diuretics. Remember, it's not like normally we used to give every patient diuretics even if they have some ankle edema, but it's not the case in Australia. In Australia, usually when a patient develops pulmonary edema due to heart failure, usually you should start the patient with furosemide. But most of the time, yeah, the heart failure patient usually gets diuretics like thiazides or furosemide. But the main indication of starting it immediately is pulmonary edema. Clear, everyone? Any question? The decompensated means that when you cannot control the heart failure symptoms for a patient, like patient is on medication, like patient is on the, like this patient was on let's say that digoxin, metoprolol and ACE inhibitor, and that's the same patient present to you with increasing edema of the leg, increasing shortness of breath, and also having feature of pulmonary edema like basal creps in the, when you do a chest x-ray you see the congested lungs. That means that this patient is having decompensated, which means unstable heart failure. Compensated means you have given medications and patient symptoms are well controlled. That means it's stable heart failure. Yep. So we don't count on ankle edema only to say it's as a decompensated. Okay, and every patient with heart failure will have some ankle edema. So it doesn't give you decompensation. When a patient has increasing shortness of breath, pulmonary edema features, then it's a full-blown picture of decompensation. Yep, that's right, Dr. Muniba. So usually the main indication of starting a patient with diuretics is when you get lung symptoms. That's the main indication. A middle-aged man who is a known hypertensive started feeling dizziness and feels his heart is racing. So feeling dizzy, having palpitation occurred after running. There was a history of travel few days ago. He is on irbesartan and hydrochlorothiazides and well-controlled hypertension. No mention of diabetes. Blood pressure 138 by 78 with no postural change. Pulse rate 110. Saturation 93. Asked what is the most appropriate next investigation. What do you think in this patient you should first think about? A patient who is coming to you with palpitations and dizziness with a history of travel, what is the vital thing you should rule out? Dr. Tahmina, no, it's not an indication to start fusemide if there is only ankle edema or leg edema. But if you start it, it's not nothing abnormal, but it's not the indication. Many patients usually get it just because of leg edema, but for the AMC purpose, keep it for pulmonary edema, start the fusemide. So in this case, what do you think this patient is having? Yeah, pulmonary embolism, right? So good. You see that any patient having tachycardia, hypoxia with a history of travel history and having a palpitation, you should always think about pulmonary embolism. And for next investigation, remember, this is the vital part. In every cases, next investigation, usually we start with more simpler investigation like ECG, chest X-ray. But for pulmonary embolism, if you suspect it, you go immediately for CTPA. You don't wait for any other like X-ray, ECG, or a CTPA. If this patient having some chest pain, you could do initially ECG, but obviously this patient mainly having palpitation and dizziness with tachycardia and hypoxia, that's an indication of going immediately for a CTPA. D-dimer is a non-specific investigation for pulmonary embolism. So we don't usually do D-dimer to find out pulmonary embolism unless they are very low risk. As I said, Dr. Francis, even if chest X-ray was in the option and they ask next investigation for pulmonary embolism, you don't have the time to do a chest X-ray. Chest X-ray cannot diagnose pulmonary embolism. You will not get anything in chest X-ray if it's a PE, just a normal X-ray. In very rare cases, you can get a waist-shaped shadow if there is pulmonary infarction, but it's very, very unlikely and rare. So we don't do chest X-ray for that. We will go for CTPA immediately if we find appropriate history, like a patient having palpitation, that means having tachycardia and having a recent travel history, that's PE. First of all, rule that out, then think about other things. Yeah, yeah. If like obviously PE doesn't come with fever, okay? If it is a fever, shortness of breath, then you go for chest X-ray. So it depends on how the patient presents to you. And Dr. Joe, D-dimer is very unlikely to be an answer in your exam because it's a non-specific investigation. It can be elevated in many other causes Like if a patient having infection, any inflammation, if patient is an anti-cancer treatment, many things can increase the D dimer. So normally we don't do it. But if you really want to know, like we do Wells scoring to find out the high risk and low risk cases. Okay. And if the Wells score is less than 4, sometimes we do D-dimer. But for the purpose of AMC, please keep it as a CTPA if you see that this patient is having a travel history and having palpitation, tachycardia, hypoxia. These are very, very high risk patient to have a PE. Now ABG or VVG, if it is in the option, initially we always do that. You can do ABG, VVG if that is in the option. Okay, that's an option you can choose. Mainly ABG will be indicated if this patient has hypoxia only. If only palpitation, then again ABG will not be a good option to choose. For hypoxia only, you can do a ABG. Clear? So these are the very important thing to remember. If a patient has a travel history and comes to you with palpitation, always think about PE first. What are the other risk factors to develop a pulmonary embolism? Always look at these sort of things in the question. Look for travel history, look for any recent surgery or trauma, mainly if there is a hip replacement or knee replacement surgery or hip fracture, knee fracture. These are very, very high risk to develop DVT followed by PE. And then if a patient is pregnant, if patient is on oral contraceptive pill or hormonal replacement therapy, if patient has varicose vein, especially bilateral varicose vein, if patient is having ongoing cancer or on cancer treatment, these patients are high risk to develop PE. So always look for those sort of things when you think about pulmonary embolism. But travel history is very common. For hypoxia, we will go for, if they ask initial or next, first option will be ABG. Okay, doctor? Otherwise, if not hypoxia, if there is no hypoxia in this question, you will go for CTPA directly. Now, for pregnant women, we don't do CTPA, we do VQA scan. That is the only time we do a VQA scan. Clear? Any question? No, it's not. For pregnancy, never do D-dimer because pregnancy itself can increase D-dimer. So if it's a pregnant woman, doing a D-dimer is totally worthless. Never do D-dimer for a pregnant woman because pregnancy itself increases your D-dimer. Okay, so it's not indicated to do D-dimer in case of pregnant women. Go for VQA scan directly. But for reproductive age patient, we can go for CTPA. We don't need to, like, if it's a reproductive age, there are chances that patient, the CT can increase the risk of breast cancer, but it's not that much severe risk that you need to do a VQA scan for them. So because still now in Australia, VQA scan is not available in every setting. Only in tertiary hospital, there are VQA scan. So still it's very hard to find it out. So normally, even if it's not a pregnant woman, CTPA is indicated. The Dr. Francis or any of you, I know this is a very complicated topic. I have just started to discuss. So remember one thing: if you think this patient having PE, you you do CTPA or VQ scan depending on the pregnancy and the other conditions. You don't do chest X-ray for pulmonary embolism. That's the main thing. Even if they ask initial, even if they ask next investigation. Okay, there is no indication to do a chest X-ray to diagnose PE. And Dr. Ridima, this is pneumonia. So a lady has been traveling in an airplane after 2 days from the UK, presented with dyspnea, 38 temperature, chest pain on coughing, which is a pleuritic chest pain. Okay, and also there is some crackles, which is this is a pneumonia. It's not pulmonary embolism. Even though there is travel history, but the other things doesn't go with the PE. Cool. Next, there is a patient in which you have got a ECG with bradycardia and prolonged QT syndrome. In scenario, patient came with chest pain for 15 minutes and relieved by rest. Troponin is normal, pulse normal and regular, blood pressure normal. What to do next? Now look at the question: ECG with bradycardia, prolonged QT syndrome, patient coming to you with chest pain for 15 minutes, relieved by rest. To help you, this is a patient of 50-year-old male. So 50-year-old male coming to you with chest pain for 15 minutes, relieved by rest, troponin normal, pulse normal, regular, blood pressure normal, but you have found in the ECG there is bradycardia. What do you do next? Repeat troponin, echo, coronary angiography, repeat ECG. Now, 50-year-old man, even if it is relieved by rest, they are high-risk patient. And bradycardia can be a presentation of inferior MI. So inferior MI patient or underlying ischemic heart disease patient can have prolonged QT bradycardia. So it's a 50-year elderly or middle-aged patient having chest pain. Even if it is relieved by rest, we will always do the full cardiac investigation, which means that you need to at least do a repeat troponin and repeat ECG after the initial 4-hour ECG and troponin comes normal. So normally if within 4 hours of chest pain you did a troponin and ECG, it came as normal, then you do a repeat ECG and repeat troponin in the next 2 to 3 hours time. Clear? So this patient will get repeat ECG first. Obviously, repeat troponin also will be done, but if you want to choose between 1 and 4, then repeat ECG will be the best option. Okay, but at this moment, there is no indication of doing a echo. There is no indication of doing a coronary angiography at this point of time. Why we would do an echocardiogram as a next investigation in this patient? Does echo can echo help with uh, myocardial infarction? Sometimes it can, but it's not like a diagnostic factor. For echo is usually for heart failure, regional wall motion abnormality, valvular heart diseases, then we do echo. But this patient obviously having ischemic heart disease, right? And also having bradycardia and prolonged QT. So this patient, first of all, we need to make sure that he doesn't have MI at this point because patient presented to you with chest pain. So any patient elderly who is having chest pain, even if it is relieved by rest or even if it is relieved by GTN, full cardiac investigation should be done. And WPW syndrome doesn't present with bradycardia. It's a type of supraventricular tachycardia. So patient usually will have tachycardia rather than bradycardia in WPW syndrome. We'll discuss those sort of things, okay? But WPW syndrome doesn't present to you with prolonged QT or brady. And angiography, remember, angiography is at the last step. Like, what will be the step of choice in this patient? That this is a 50-year-old having, most likely this is an unstable angina. But what if it is not an unstable angina? It's a MI or a non-still elevated MI. If you don't do repeat troponin, repeat ECG, you can miss it. So you have to obviously do that. Remember, in Australia, chest pain is a category 2. Category 2 means that you need to treat any chest pain, even if it is like, if it sounds like a case of gastroesophageal reflux disease, that patient should be seen within 2 minutes of presentation to the hospital. So category 2 is like a very, very high priority patients. So those patients, even if it is relieved by rest, even when the patient came to you through ambulance, they have given everything, and when they present to you, they are totally pain free. That doesn't indicate that you will stop there. You have to do all the cardiac investigations until you go to the last and you treat the cause. So last option, first of all, you did the ECG and troponin that came negative. Then you again repeat it in 2 to 3 hours time. That also came as negative. Then if this patient is high risk, obviously this patient is high risk because patient having chest pain, having ECG abnormality. So we need to do more investigation. So there will be option of doing exercise tolerance test. There will be option of doing a stress echo if patient cannot do, uh, sorry, there will be option of doing chemical echocardiogram, okay, or dobutamine echocardiogram if patient cannot tolerate exercise. So all those things have to be done. If those tolerance test shows any ischemia during exercise or during stress, then you do an angiogram to find out how much obstruction is there. Then with the if you find out blockage in the coronary artery, then you can prophylactically provide stent, you can provide coronary artery bypass grafting to this patient. So in Australia, these things are very commonly, we do these sort of things. Okay. So in Australia, this will be done by the cardiac specialist. Is very commonly every patient will be shorted out. So very careful with the chest pain questions. Even in here, there was the ETT option, Dr. Saada. We would do a repeat ECG and repeat troponin first. Then if this was normal, then we would go for ETT. Okay, we discussed these sort of things previously. Oh, that's a good question, Dr. Mimo. So I know like VQ scan you cannot do if there is underlying lung problems. But that doesn't mean every patient who is having a PE, chances of PE, you need to do an X-ray. Now see that the patients with pregnant patient, you are doing a VQ scan because you don't want the radiation effect for the baby, right? That's the reason. Now, if you do an X-ray, you are doing the radiation. So there is no good to do a X-ray in this patient. So that is the reason usually if the patient says that they had some underlying asthma, COPD, bronchiectasis, fibrosis, they will know that. Or if they're having any infection, you will know, like they will say fever. So if you think it is a pneumonia, you would do a chest X-ray. Otherwise, you are not going to do that. And if there is any underlying lung condition, they will know that, like asthma, COPD, fibrosis, bronchitis, every patient knows that they are having that chronically. So no need to do that. I know the flow chart, but in case of emergency, that flow chart doesn't work. For pulmonary embolism, it's a life-saving thing. We go for CTPA VQA scan as soon as possible. I just answered the question, Dr. Francis. Okay, so that's the reason why we don't need to do the chest X-ray. Cool. 23-year-old man comes for follow-up. His bilateral arm blood pressure is 140 to 160 by 100 to 110. That means patient is having hypertension. Occasional headache is there. Rest of the physical examination and urine analysis is normal. Heart rate normal, mild LVH, beta blocker, hydrochlorothiazide, captopril was used, and still BP is high. So you can see it's a resistant hypertension. Even if you use 3 medication, still the blood pressure is not coming down. This is only possible, like this sort of resistant hypertension in a young patient usually comes, or usually they have an underlying renal artery stenosis. Renal artery stenosis, usually they are very much resistant. Even though if you give a lot of antihypertensive, it may not be totally controlled. That's one of the very common finding of renal artery stenosis. For renal artery stenosis, if you want to diagnose, how we diagnose them, we do a duplex ultrasound of the renal arteries. Okay. Then next question, women on multiple drugs, one of them was digoxin. She presented with central abdominal pain and tenderness. Her pulse was irregular. Apart from CT, what is the most appropriate next investigation? So remember, if a patient having irregular pulse, always think about AF. Now, AF patient, anytime complaining of central abdominal pain, what is your most likely cause of that? Good. Mesenteric ischemia. So mesenteric ischemia is very common in patient with atrial fibrillation, because you know that atrial fibrillation patient, they tends to form clot, and that clot can get embolism, and that embolism can block any arteries in your body. It can block carotid artery causing a stroke. It can block your mesenteric artery causing mesenteric ischemia. If there is mesenteric ischemia, patient will present to you with central abdominal pain around the umbilicus. They can also present to you with pararectal bleeding. So for mesenteric ischemia, we normally do a CT angiogram to confirm the diagnosis. But apart from that, what we can do, serum lipase, serum lactate, digoxin level, abdominal ultrasound. Now, digoxin level has nothing to do with ischemia. Serum lactate is a good investigation to do, because when a patient develops mesenteric ischemia, the part distal to the ischemia develop necrosis. And in the place of necrosis, there is production of lactic acidosis because of anaerobic ischemia. Now, for anaerobic ischemia, you will develop lactic acidosis, so your serum lactate will be elevated. That's why we do the serum lactate to diagnose this sort of condition. Next, old man taking digoxin and hydrochlorothiazide presents with palpitation. ECG shows tall peaked T wave. What is the cause of his problem? Remember, I discussed it in your theory class. So a patient is on digoxin and hydrochlorothiazide, presents with palpitation, ECG showing tall peak T wave. Can anyone tell me what's the thing going on in here? See, this patient is on hydrochlorothiazide. Hydrochlorothiazide causes hypokalemia. If you have low potassium in your body, there is a possibility of digoxin toxicity, right? Because both your both digoxin and potassium binds with the same receptor to get into the cell. Now, if there is less potassium in your body, digoxin is moving, like more digoxin is binding, right? And going into the cell, and potassium is outside. So if potassium cannot go in, what is happening? That the potassium is in the outside in your blood vessels or in your plasma. And if there is potassium in your plasma, there will be, and with more and more digoxin going in, it will cause digoxin toxicity. And later on, this digoxin toxicity will lead to hyperkalemia. If you look at this picture, see, this is sodium potassium pump. In a normal patient, this ectopics causes the inter-exchange of sodium and potassium in your cell and outside your cell. So from the extracellular or from the outside the cell, potassium go in and sodium goes out. That is the normal thing to happen. But when digoxin toxicity occurs, digoxin will bind to this receptor and it will stop this exchange. Now, if potassium cannot go into the cell, potassium will be more in your extracellular area, which will lead to hyperkalemia. Now, again, you can see there is tall peak T wave, which is a feature of hyperkalemia. Now, what is the cause of his problem? Now, what will be the cause? Is it digoxin toxicity is the cause, hypokalemia, hyperkalemia, infection, or renal failure? So obviously, from the point, I find out that it's a digoxin toxicity causing the hyperkalemia. All right, clear? So again, if you look at this picture, you can see in a normal person, the sodium potassium pump is usually regulated by this ATPase. That means sodium potassium ATPase pump. What happens that normal patient sodium goes outside the cell and potassium goes inside the cell with this pump. When a digoxin toxicity occurs, digoxin will bind to this receptor and it will inhibit sodium potassium ATPase pump. If the pump is not active, then sodium will not go out, potassium will not go in. If potassium is not going into the cell, it's all outside. Outside means in your blood, which means there is hyperkalemia. Clear? Cool. Any question? Good. So that's our diagnosis. Now, someone asked this question, I think. So, patient with systolic murmur over the left sternal border no change with respiration. Also, there is a soft mid-diastolic murmur at the apex. What is the diagnosis? Now, you have got a patient who is having two types of murmur. One is systolic murmur at the left sternal border. Left sternal border, systolic murmur, you can easily rule out aortic stenosis, right? Now, BSD can cause left sternal border murmur if it is in the lower. SD causes upper left sternal border murmur. Okay, pulmonary stenosis, it can cause it, but it doesn't cause two types of murmur. Unlikely. Now, ASD, VSD, if you go to our ASD, VSD note previously, look at this VSD. VSD causes pansystolic murmur at the left lower sternal border. That's the only murmur it causes. Pansystolic murmur at the left lower sternal border. Whereas if you look at the ASD, ASD causes diastolic rumble across the tricuspid valve sometimes if it is hemodynamically significant. So it causes diastolic rumble and also it causes systolic ejection murmur. So this is the only murmur or only septal defect which causes both murmur, diastolic rumble with a ejection systolic murmur. So that will be your answer in this case. Clear? Now this will be our today's last question to discuss. So patient on many medication, metoprolol, digoxin, furosemide, ECG was given with a Mobitz type 1 block. Mobitz type 1 is your one of the heart block and it's a type 2 block. Sorry, so there is first degree heart block, second degree heart block, third degree heart block. We'll discuss it in detail how the ECG comes with. Now first degree heart block, second degree has two types, type 1 and type 2. This patient having type 1 second degree heart block. Also having vomiting, abdominal pain. Digoxin level was there, but it was normal. What to do? Now, remember one thing. This patient is on digoxin, furosemide, metoprolol. Only two of this medication can cause or can aggravate block. One is digoxin because digoxin can aggravate heart block, and metoprolol is a beta blocker. It can also aggravate heart block. Furosemide has nothing to do with it. But you have found this patient also having vomiting abdominal pain. Do you remember that digoxin toxicity causes this sort of problem? Nausea, vomiting, abdominal pain, halos around the eyes, right? Now, this patient having symptoms, metoprolol would not cause vomiting abdominal pain. On the top of that, I said that sometimes even though digoxin level normal, it's one of the very apparent trap for you. It's a trap because if you see that digoxin level normal, most of the candidate will think that, well, if the level is normal, it's not a toxicity. But no, digoxin level doesn't indicate toxicity many times. It's a symptom which indicates the toxicity. And remember I said digoxin toxicity can cause any arrhythmia, especially it causes any type of heart block. So in this case, what you should do, first thing, any heart block, you should stop medication which can aggravate heart block. So you should stop or cease digoxin in this patient. First thing to do it, stop the medication. Also in this patient, metoprolol should be ceased, but among these two, ceasing digoxin is the most important one. If this patient did not have vomiting, abdominal pain, no feature of toxicity, first choose seizing the metoprolol. Okay, it depends on what is there in your question. Cool. Now there are lots of things to discuss about uh, the heart block management. We are not going to discuss it today. We'll do it in the ECG class. Just to let you know that this option, if you seized metoprolol and commence verapamil, what will happen? Nothing, because both of them are rate limiting. So it's not a good option. Angiography is not important for a block patient. Temporary pacemaker is indicated for second degree type 2 and third degree heart block. But for type 1, temporary pacemaker is not an option at this time. Clear? Any question so far? So today we are going to stop here, and there are still lots of questions from cardiology. Okay, it's impossible to finish it in one class, but obviously I try to answer the important ones, which will make you crazy. And there will be a lot of debate among candidates about these answers. Okay, but I can assure you whatever answer I have given, these are correct. Okay, because we are working in Australia, we know what we do here. So most likely I can say that the options I have give answered, these are not wrong. But sometimes when I will be confused, I will say that I am confused. Because yeah, it's normal to be confused. We are human, we can make error. And when I'm confused, I will say I'm confused. Okay. But these questions, it's apparently it should be fine. Dr. Asha, your question, this remember when a patient come to you, you need to this question is about categorizing your patient. So you are in a busy department of emergency. There are rush of patients. You have found a patient in which, like, one patient is aggressive with psychotic behavior, another patient with acute poisoning coming frothing from the mouth, another is with severe chest pain with syncope, another with bleeding from the head, another with burned patient in 36%. Among all these patients, the most important patient is cardiac patient, because this patient you can save. You can save this patient, and if you delay, you can lose this patient within a second. Okay, so among these are all these patients are very important, but cardiac patients are always the most important patient to you. All right, so that was all for today's session, I think. So we'll stop here tonight. If you have any difficulty with any question, feel free to upload those questions in our first aid AMC MCQ group. There will be someone to answer those questions. All right. Also, if I come across, I can also try to answer if I get any time. But otherwise, try to do question solving in the group. It will help you to understand, and it will help you to find out that how is your position and how good you are in answering questions. That's very important to make your confidence. And also, you know that we are having the last class tomorrow of our free 2-week session. So if you guys are still anyone interested to join the session, this week is the last time to get admitted. So make sure that you send us email or messenger that you want to join that session. Otherwise, this, the seats are getting like unavailable after this week. So please try to contact with us. Otherwise, sometimes what will happen, we may not get the enough seat for you to start this course. Then you need to wait for the next 5 months, because we run course every 5 months. So it will be difficult for any of you. So if you think that you want to join any course and if you feel it better, always join when you get it available. Who knows what happens? Okay. So always is better to get into a course, get the idea about what you want, what you need to read for passing this exam, and then take time to prepare. Yeah, the schedule is updated in your Facebook. Have a look. It's tomorrow. Now, tomorrow the class will be on a little late, 9 p.m. Sydney time rather than 8 p.m. Sydney time. Okay, so I'll upload that the change tonight. But just, I know that you guys will join, because you guys are joining for the last sessions, most of you. So our class will be started on 9 p.m. Sydney time tomorrow, just because I got some urgent thing to do, so I might get late. So that's why I don't want to make you waited for class. Okay. All right, then. Have a good night. We'll see you tomorrow with, we'll do some August question discussion tomorrow. And tomorrow is the last session of free 2 week session. And after that, we will continue with our 5 months batch, the, the rest of the session. Okay, cool. Thank you all for joining these sessions. You guys are making it good because you guys are answering the questions, you are asking the questions. That's how the classes are. In the interaction between a student and a mentor is really important to get the best benefit out of a course. So that's very, very important. Keep it on, it will help you. Thank you. Have a good night.